Hello, everyone, and welcome to the Babies in Common show. I'm Jeanette.
And I'm Melissa. Welcome, listeners. Please note that any information shared during this podcast is not to be taken as medical advice. Please consult your own care providers for questions about you or your baby's health and visit babiesincommon.com/disclaimer to read more.
Cool. So our honored guest today is Ketura'h Edwards-Robinson, a native of Bostonian who's currently working in her home city as a nurse practitioner, primarily in the area of women's health. However, one thing that makes Ketura'h special, of course, there's many things, is that in the past year, Ketura'h trained to become a birth doula and is now serving clients in her community with Accompany Doula Care, a local doula agency that's helped develop a model of care where their doulas are reimbursed by the client's health insurance, which is amazing. And we hope that that model takes off for sure.
Absolutely. Amazing and beneficial for everybody involved.
And I know our dear friend Lorenza Holt has worked on that for many, many years.
Yes. Love Lorenza. Ketura'h graduated from Smith College with a bachelor's of arts in chemistry in 2011, which is awesome because I went to UMass, so go 5 colleges. And from there, obtained her master's of science in women's health nursing from Boston College in 2013, and then her gerontological adult NP postmaster certificate from UMass Boston in 2019. With all that education, Ketura'h has served her community in many ways. She has served as a women's health nurse practitioner at the Suffolk County Jail, a primary care clinical care manager, an OB-GYN nurse like me, and even a pediatric nurse. She also has experience providing acute treatment for patients experiencing substance use disorders and is a sexual assault nurse examiner for the Massachusetts Department of Public Health, which is an incredibly important job. And I appreciate every one of you that does that incredibly important role. So thanks for being with us today, Ketura'h. Your breadth of experience is amazing. And I am in awe already. I know Jeanette is too. So I can't wait to hear more about you.
Oh, thank you for having me.
Awesome. Well, let's start by explaining for everybody, because I know we, in our community, I know I talk about nurse practitioners once in a while, and I'm not 100% sure that everybody has an idea of what they are. So what is, people don't know that nurse practitioners can provide primary care, gynecological care, pediatric care. You've done a bunch of different things as well, older people, gerontological care. So what is a nurse practitioner? How does their expertise and scope of practice differ from other clinicians like a nurse or a doctor or a midwife or a physician's assistant?
Right. So first off, start out by saying that nurse practitioners are legalized to practice in all 50 states of our great country sometimes. But their scope of practice can vary depending on the state that you're in. Fortunately, in Massachusetts, as a nurse practitioner, I do have what we call full authority, full prescription authority and practice authority. So I can practice autonomously, so by myself or in collaboration with a physician, and I can write my own prescriptions.
And that's a fairly new change, if I remember, correct?
Yes, Massachusetts has been doing a lot of great work to give nurse practitioners autonomy.
Yeah, because before that, a lot of people don't understand that basically you would have to find these practice arrangements where, even though you were seeing your own patients and writing your own prescriptions, you'd have to have a physician, a doctor, sign off on all of your prescriptions, which in practice, as someone who worked in an OB-GYN office with nurse practitioners and midwives and doctors, it was really like having someone sign all of your notes all at the end of the day.
It was like a chaperone. You couldn't be you can't be trusted. But like I said, fortunately, we've come a long way since I've even started practicing as a nurse practitioner. And yes, nurse practitioners have gained a lot of autonomy in Massachusetts. It's a great state to practice in as a nurse practitioner.
So, as we discussed in your intro, you worked as a pediatric nurse and an OB-GYN nurse before going back to school for your master's and then becoming an advanced practice nurse, which when we say APRN or advanced practice registered nurse, we mean careers like nurse practitioner, certified nurse midwife, certified nurse anesthetist, or clinical nurse specialist, right? Those are the big 4. And we call them, as an umbrella term, advanced practice nurse. So what drew you to go back to school for that role? What was it about the role of the nurse practitioner, that you really liked and wanted to change careers? Because it's not the same thing as working in a nursing role, whether you're an LPN or an RN. It's a completely different scope of practice.
Yes, like, if I could simplify it, a nurse does provide patient care, but it's with the direction of a provider, a nurse practitioner, a physician assistant, or a doctor, versus with a nurse practitioner, I am giving the orders.
Amen. Officially, not like unofficially.
Yes, exactly. For me, it was actually when I was in Smith College, where I was majoring in chemistry. I was actually on the pre-med track. And during that journey was just not so much hitting roadblocks. I called them roadblocks, but it was just more what I think were just signs for me to know that medicine, the route that I was trying to take to go into healthcare wasn't in medicine. Well, the first roadblock would be that I did not want to take physics. Not even gonna lie to you. Like, I tell everyone that. They think I'm joking. They think it's like my opener for about my journey. No, I just did not want to take physics in college.
I never took it either. And I have many family members who are engineers, and my daughter is majoring in physics. I'm like, I don't even want to take that class ever. So
I'm impressed that you were a chemistry major, because
right,
I am a science geek, but I cried every day of organic chemistry. Like, I really
see, and I was organic chemist. Like, yeah, shout out to Shea Lab at Smith College. But no, like, I loved organic chemistry. Love-hate relationship with inorganic chemistry. But yeah, so I refused to take physics. And then just engaging with, if I'm being honest, physicians, and just getting a sense of how they practice. And if I'm being also the personality, it didn't feel like it fit me. But I knew that I was interested in healthcare, and I also knew that I was interested in women's healthcare. I mean, I went to Smith College, like that. if we're gonna be honest. So the first job I discovered was the sexual assault nurse examiner program, and CSI was big back then. So I was just like, this is it. This is like, I was watching, about to date myself, a TV show called Crossing Jordan. I don't know if anyone remembered that. So like, that was like my journey. Like, I was like, this is what I'm gonna do. And then I go look into it more, and it says, oh, you need 2 years of nursing experience. I was like, oh, so this is not gonna be like my job right out of school. So that's actually how I discovered how I became interested in becoming a nurse practitioner, was just looking into this role of being a sexual assault nurse examiner. And then I already have a bachelor. I was about to graduate from Smith with a bachelor's in chemistry. I did my time. I just knew that going to get a bachelor's for me in nursing wasn't enough. Like, that wasn't going, like, I already had a bachelor's. I wanted something else. And that's how I actually discovered there are, across the state, there are a few direct entry master's programs, which you come in as a student, you're someone who has a bachelor's in a non-nursing degree. So in my case, chemistry. And then it can be anywhere from 2 to 4 year of a program where they're cramming 4 years of the RN school, nursing school, like your BSN curriculum, into 1 to 2 years for you to be able to sit down for your boards. And then the other 1 to 2 years again is the master's portion for you to become a nurse practitioner. So when I became a nurse, RN, I didn't have a bachelor's of science in nursing. I have a BA in chemistry, but I was a registered nurse. And I practiced as a registered nurse with a BA in chemistry only for 1 year, until I graduated the following year with my master's in nursing. So my master's in nursing was and is my only nursing degree.
Wow. Right. And that's not that uncommon, because I feel like nursing, people have this idea that, nurses, they had an ailing loved one who was, cared for by this angelic nurse. And then, and at such a tender young age, they were inspired to, like Florence Nightingale, to go into nursing. And the top 10 nurses in my nursing program when I graduated at UMass, myself included, I can say that. But yeah. we all entered college with different majors and then
Yep.
found our way into nursing.
Mhm.
And, you know, that kind of enriched, I feel like the people that were in the nursing program, because it wasn't just people that had, you know, only thought about being nurses. It was people that had, you know, I had a microbiology background,
Mhm.
and other people were, you know, nurses as a second career, and they come with all of this life experience, you know, or a BA in another program to the world of nursing. And that really enriches, I feel like, the world of nursing, because it's so diverse. There are so many ways you can take being a nurse, which is one of the things I love about it. So
No, same. And I think that is what, in essence, drew me just to nursing. In general, it's just like it looks at the person not just from the medical side of things, but as a whole person. And so, I mean, using those key terms, social determinants of health. So, yes, this patient has high blood pressure, but maybe we can get their blood pressure lower if we can help them get if they are living in a food desert, so we need to help them get better healthy food options. And that's where the value of having nurses from different walks of life. So I had I had fellow students, one in my nursing program, who had like majored in philosophy as their first degree, finance,
Wow.
physical, they're gonna kill me, I can't remember what kinesiology, just like an array, just an array of knowledge from different perspectives. And I think that's what nursing promotes, is that you need to look at these different aspects of the person in order to provide whole person care.
Yeah.
Amen. So if I remember what you said correctly in the technical way, so the advanced practice nurse is also, one of them is a certified nurse midwife, right?
Yes.
And you and certified nurse midwives also provide OB-GYN care. So what would you say are the differences between a certified nurse midwife, their scope of service or scope of practice, versus yours as a nurse practitioner who works in OB-GYN?
I do not catch babies.
Right.
Period.
Period. And that is okay. That's okay. I do not catch babies. Do not have a desire to, if I'm being honest. I think that is wonderful, godlike work. Not my ministry though. And then there are truly, in my opinion, no other differences. What makes it appear that certified nurse midwives and women's health nurse practitioners have such a vast difference in their scope of practice is more the medical system that we work in. So certified nurse midwives are pigeonholed, oftentimes, in my opinion, to just do OB care and the basics of gynecological care, like a well woman exam and some like family planning services. Now, depending on where that certified nurse midwife is, you know, if they're in a more rural area or an area that has limited resources, they will more than likely have the opportunity to, I guess, offer that full comprehensive scope of practice in women's health, much like a women's health nurse practitioner. So I do well woman exams. I can manage clients who have chronic, who suffer from chronic diseases or illnesses such as uterine fibroids, painful periods. I help postmenopausal patients, as well as doing OB care and postpartum care and family planning services.
Yeah. And if I may get on my nursing soapbox for a minute, because, you know,
Absolutely.
Of all episodes, Melissa, I think this one's an appropriate one. Okay.
Yeah, right. You know, it's funny because I also went to school, microbiology, pre-med. And when I decided to switch into nursing, I, you know, right off the bat, like, you know, so I'm this, you know, bright-eyed, bushy-tailed 18-year-old. I'm in micro pre-med. And one of the first seminars that we had wasn't about health at all. Again, we were freshman year. We are not near graduation. It was just how to get into medical school. And it was so very like, you have to take these classes, you have to get these grades, you have to schmooze these people, you have to take these electives, you have to show that you're worldly. So maybe you need to join the Peace Corps before you apply to medical school, you know. And it was like, you have to get a minor.
I should have done that.
Yeah, exactly.
I could have been a doctor.
okay, you're a microbiology major, great, but you also need a second major, and that needs to be like dance, something that makes you special, you know? And it was like, oh my God, like this is, you know, this seems, and then I don't get to start my life until I'm like 33 because I have to like go to medical school and then residency. And it just really, the whole like culture around it turned me off. Now, I don't want any doctors listening, if there would be, to be upset, you know, thinking that I am disparaging doctors. I'm not. There are so many OBs that I love that are incredible, that give great care. But when you think about, you know, maybe there are people that are receiving care that don't know the difference, but maybe there are young people in our podcast listening audience that are thinking about, hey, I like this idea of working with women, or, you know, women who are female assigned at birth, people who are female assigned at birth bodies. And maybe I'll be an OB-GYN. And what they don't realize is that if you're interested in primarily a wellness model of care, if you're interested in what Ketura'h is talking about, looking at the whole person, their living situation, their resources, their community, you know, to provide that type of care. What you're going to learn in OB-GYN residency is surgery. OB-GYNs are primarily surgeons, people who go into OB-GYN. And I've asked dozens and dozens and dozens of people, why did you become an OB-GYN? Sometimes because they're awesome and I want to know. And other times I'm like, why? Why did you go into this? You know? And they're like, you know, because I was really interested in surgery. 9 times out of 10, I was really interested in surgery, but I didn't want to do general surgery. And I did my OB rotation, and I really liked that while doing surgery, you could also do some happy stuff like catching babies. Rarely, I'm not saying it's impossible, but rarely do I hear, I loved providing well woman care. That's why I went to become an OB-GYN. Almost always it's primarily surgical based or pathology based, meaning I love the diagnosis of disease, you know, and women's health like women's pathology, like gynecological cancer and fibroids and menorrhagia and adenomyosis and all these things was very clinically interesting to me.
And that's important and lovely.
Very important.
Right,
I mean,
exactly.
we need people that know how to do uterine ablations. We need people that know how to do hysterectomies. We need people that know how to do C-sections. But, you know, if you're interested in a women's health focus, there are so many other avenues besides medical school. And one thing that always bothered me. Yeah, right? Always
and
bothered
that's all we're
me.
saying, doctor.
Seriously, was like they would try to be giving me a compliment. I'm sure you've heard this too, Ketura'h. I guarantee it. Oh my God, you're so smart. You've explained this to me in such a wonderful way. Like, why didn't you go to medical school? I'm like, oh, like nurses are smart.
Explain it that way.
They are smart, independent nursing professionals with an entirely different scope of practice than doctors. We work together as part of an interdisciplinary care team. So the NP role is not what some people say. It's like a mini doctor. It's not a mini doctor. They are completely different roles with many wonderful points of view, experience, and expertise that they bring to the table. So thank you for coming on our show.
No, I appreciate it. No, and like, you know, just to, you know, piggyback on everything that you're saying. So I'll go to my physician colleagues when I feel that I'm out of my depth. Like I need that specialized care, you know, that specialized education that they did for those 8 to 10 years. Like I personally know when to refer or to consult. But at the same time, what it doesn't get talked about, my colleagues who are physicians, they also come to me, not so much
100%.
for that. And what they more inquire about are the social related things. That's where, in my opinion, as an advanced practice nurse, I have a greater skill set. I have more tools than they may have been provided in their education. But like you said, that's where that collaboration comes in, and everyone just needs to come, you know, with no ego and just understand that the goal is just to provide good, comprehensive care to our patients.
Yeah, absolutely. I used to work on a surgical floor, a general surgical floor. And so let's say you had like severe Crohn's disease or some type of, you know, intestinal cancer, right? Now you have a fantastic surgeon, world renowned, who creates this amazing, perfect colostomy for you, right? And you have a perfect recovery and you don't get an infection and it works amazingly. That's great. We need that doctor to do that. But do you know who is
Absolutely.
not teaching you how to live with a colostomy? You know who is not helping you get the mental health support that you need now that you are literally pooping out of a bag in the side of your body? You know who's
this
teaching your
conversation took
family?
a turn, Melissa.
No, but you know what I'm saying? You know, family that's like teaching you how to take care of someone who now has this, like that's a nurse.
Yes, right.
That's a nurse.
Yeah,
It's not.
it's just differences. Yeah, every
differences.
role has its strengths and weaknesses. And as long as everyone acknowledges that, and again, just acknowledge what the final result should be, which is good care for the patient.
Absolutely.
Everything should be easy.
So one of the things you mentioned is contraceptive care,
Yes.
which is one of my favorite topics. And since we are babies in common, many of our listeners are about to be breastfeeding their baby and in need of contraception, right? So when you are counseling lactating people specifically, what are your favorite contraception recommendations and why?
So I don't have any favorites. What I will say and what I encourage everyone listening with their OB care is to first ask themselves, like, what do they want? What do they what are they most comfortable with? Do they find that they'll be able to take something daily versus do they just want to, as I like to use, set it and forget it? So that would, open up a conversation more to the long acting reversible contraceptions like the implant or the IUDs. The one thing I will say with any birth control that does have estrogen in it, so that's most of the birth control pills, the vaginal ring, the patch, it's not recommended that a birthing person, so a woman who would need the contraception, does not start that method until 21 days after they've delivered, just because of increased risk for them to develop a blood clot. So the methods that are, I guess, safest to use immediately after delivery would be progesterone only methods. So that's the Depo-Provera injectable. There is one birth control pill that you can take that only has progesterone in it. There's the hormonal IUDs, which are the Mirena, Skyla, and the non-hormonal IUDs, like the Paragard, and that good old trusty condom. We always forget about him, but he is standing the test of time.
The issue with condoms, though,
want to give him a shout out.
Exactly, is you have to use them. And I don't say that as a joke. I mean, like, my joke at the 3-week postpartum visit when I visit our home birth clients is, so remember, you are going to pop out an egg and ovulate 2 weeks before you get that, hey, I'm your period again, first post-baby period. And when that egg pops out, that's when all of a sudden your partner, who you were not interested in for the last, 6 weeks or 6 months or 6 years, is like looking pretty damn fine to you. So you gotta have them on hand, because some people haven't had to worry about it for 9 months. They don't necessarily, think about using a condom because they haven't had to. And we really, really, as we talked about in the episode with Dr. Kelly Bowen a couple months back, you really want to give proper spacing to those pregnancies so that you can replenish your body and give your body and your baby what they need to have a healthy pregnancy.
And that's an essence. Sorry, go ahead.
Well, the other thing that about some of the ones that you mentioned, the hormonal ones, there's research that will tell us that the, Depo-Provera, the Mirena, that those don't cause problems with lactation. But there are thousands of private practice lactation consultants who will tell you otherwise. So the pulse right now in lactation land is that you want to really be sure that you have an abundance of milk before you start to use anything that has hormonal, especially the Depo-Provera, like several months after lactation. There's unfortunately people who are being given that without full informed consent in hospitals right after giving birth, and then their milk just doesn't even come in. And that is so sad. But then you can talk to their care providers and they'll be like, well, yeah, but the research says that's fine. It's like, I don't know who's doing those studies, but we're finding that in clinical care that is a problem. And I have met many people in my practice alone who have a lowered milk supply when they get the Mirena or one of the hormonal IUDs. So, and it's random, like who it happens to. And at least an IUD, you can take it out, but a shot of Depo-Provera, you can't do anything about
it's
that.
good for 3 months. Yep.
Yeah.
No, so it's funny that you even mentioned like, what you're seeing clinically. in preparation for this, for our meeting today or our talk today, I did I said, let me just go look, just to see what information's out there. Cause I mean, I do recall, in my own nursing education being counseled that, so not only the focus wasn't so much on the increased risk for the blood clots with using the estrogen birth control that has estrogen in it, directly, soon after delivery. It was more about the drying up of the milk. So, reducing the milk supply. I can't find that information anywhere. Like in, the medical journals that, I often resort.
Do you know why? Do you know why that is?
I don't know if I can say. What do you tell me what you think?
because what we notice, not at an individual care provider level, but as an American medical system, they do not care about research on lactation. And that's why so much of the actual research that's done on lactation is extrapolated from dairy cow industry, which is fascinating.
Okay, yes,
in the last 5 or 10 years, in the last 5 or 10 years, there's been more research on it, on lactation, but it's not that common. And so, in the medical communities, they're not even learning much about it, which I want to ask you about that later. But, it's a sad situation, because then you go look and care providers will be like, well, that's what I saw in the research. And you're like, oh, I know it, it's published. Just like, this is always a fun one for me. The fact that if you are exclusively breastfeeding your baby for, even at least once at night, all around the clock, for the first 6 months, so there's no food, the only thing that passes over your baby's lips besides human milk might be medicine and maybe a vitamin, right? That's considered exclusive breastfeeding. Those people, according to the research, should not be getting their periods back, but they do. And people get pregnant 4 weeks out of having a baby,
I was gonna get on my soapbox when we were talking about the contraception. Said I want to talk to the mothers out there. It's really the veterans, because it's not the new mothers.
Okay.
But for new mothers, don't listen to the veteran mothers about if you're exclusively breastfeeding, like you don't need to be on birth control. Your ovulation is suppressed. That is not true. Right. That is not true. You can ovulate 21 days after you deliver. And also, your baby's feeding habits are going to change as he or she, they get older. So you're not having that same steady suppression of ovulation that you may have been having when you were truly exclusively breastfeeding month 1 versus month 4 through 6.
Right.
So yes, if you birth spacing is absolutely important, as Jeanette said, for healing of the body. Like you need to give you grew a whole person, like a horse or a giraffe. I'm sorry, it's beautiful and fascinating to me. Like I love just the experience from the outside, not personally. I love the experience. And that's a lot, like so much energy, time, like you need, and the same amount of time that you took to grow this person, you need that same amount of time to let your body heal.
Well, just think of where the organs went. Like they go so far north. Like some of the organs go so far north. Like it takes some time for them to drop down. And you probably remember, Melissa, like you feel it in your stomach. You're like whoop, whoop.
Yeah.
So there's changes for sure.
And sometimes things settle at new locations, so you gotta get used to that.
Yeah, like my breasts are much lower than
or the bladder.
No, it's true. Right. It's true.
Yes. So speaking of breastfeeding, so Ketura'h, you and I met recently when you took a workshop that I created and lead on pumping and bottle feeding for perinatal professionals. And I love teaching these workshops because I get to know about, it's rare for medical and nursing education to include evidence-based, comprehensive, and up-to-date lactation education. So can you share with our listeners a bit about what you personally learned about lactation and breastfeeding when you were in women's health, nurse practitioner school, and in nursing school? Did you feel the need to further your education to work in women's health? Do all of your colleagues feel like they need to learn about lactation and breastfeeding and chest feeding and all of that? So what do you think?
In short, I learned nothing that the general public doesn't already know. And with that being said, also learned some incorrect things that the general public already knows. I'm gonna be honest. I do not recall having a lesson that was specifically focused solely on breastfeeding and lactation. I know we talked about it, absolutely. But yes, after I graduated, I mean, and the funny thing is that they say this to us when we're in school, that, you know, some of your education is going to need to happen after you graduate and as you practice, which was exciting, and I accepted it. But now in retrospect, that's like a scary thing that
it's also random. Like, so
yeah,
you pick a topic, and there might be one person who graduated who learns that topic, and that's great for her clients. But what if 10 others never learn that?
And so it really came down to what was taught in the class and where you were placed for clinicals. So if you didn't have that exposure, which in my opinion, I didn't, yeah, there was a lot of self-teaching once I graduated. And I think that's for NPs as well as MDs, because I've seen it in my own practice. I'm going to refer you to the lactation consultant instead
Oh
of,
man, if we could have people say that more often. That does not happen very often, unfortunately.
I know.
Well, my clinic is fortunate where one of our nurse practitioners is a certified lactation consultant. But other than that, I don't know if we would be able to have that resource for our patients. So I do feel very fortunate for that. But yeah, I recognize that lack of knowledge, and I know we're going to talk about it later. That also is what led me to my journey on becoming a birth doula as well, because gaps in my knowledge and education about just like the birth experience and the pregnancy experience as a whole, from the beginning, from preconception to postpartum. So I mean, I took Jeanette's class most recently, but my work really started as far back, I would say 2017, 2018. So that was, what is that? That's three, almost 4 years out of graduating from my master's program. You know, really investing that time and resource into like going out and looking for resources to learn about breastfeeding. So I took a wonderful course, an intro to breastfeeding for perinatal workers, through the Boston Association of Childbirth Education, Nursing Mothers Council. I always want to make sure I get that. So BASE, I think is what it's short for. I also became a centering pregnancy co-facilitator around that.
I love centering pregnancy.
I do as well. That was back in 2014. So that's actually where I got a good amount of like my first exposure to the fact that I knew nothing about breastfeeding, was when I had to facilitate my centering pregnancy programs. And one of the sessions topics are around breastfeeding, and me and the patients were learning together that first and I was like, all right, I have to do better. And yeah, but I also think that's the sign for me of a good provider as well. I am always learning, and I should always be learning, because things are changing. And I want to make sure that I am staying up to date with the most recent information and practicing evidence-based care.
Amen to that. I love being a learner, and I love collaborating with other people who want to be learners. You know, it's like very exciting.
Absolutely. Yeah.
To work with people that are like, oh wow, did you see this new study? And oh, did you see this new protocol on how to treat hypertension? It's like, ooh, you know, yeah, that's right. You know, I love that. And so this is a great segue actually to our next question, which is, you are serving as a birth doula for Accompany Doula Care, which is
unusual.
Remarkable. Yeah, it's unusual. It's uncommon to meet doulas who were medical professionals before becoming doulas. I mean, if anything, it's the other way around. Sometimes people go into doula work to get a foot in the door in the birth world, and then maybe go on to become a nurse or a nurse practitioner or a midwife. But in my experience, even still, that's pretty uncommon. And doulas and medical professionals are often like two separate islands. And that's not necessarily a bad thing, because one of the benefits of having a doula support you is that they are outside of the medical team, and then they can be an advocate for you in that way. But still, I mean, this is fairly uncommon. So I'd love to know what inspired you. You know, you have a master's degree, postmaster's certificate, you have prescriptive privileges, and you can run your own practice. And now you're like, I'm going to be a doula, which honestly, it shouldn't be that. They should be considered and viewed as part of an interdisciplinary healthcare team. But but doulas are definitely low man on the totem pole when it comes to like the players in the room.
Absolutely.
You know, so the hierarchy, doulas are kind of on the bottom. So tell me more.
Again, it was just in my own practice, and I just always want to be the best provider that I can be for my clients. I work in a community health center setting, so some assumptions and some are actual reality. Some of my patients have limited resources, so they don't have that, and they have limited support. And because I do work in a clinic setting that works with that only has physicians, when you go into the hospital, it's not me that's there, because as we said, I don't catch babies. And how the hospital dynamic, how the hospital model is that even if you were seeing a physician at my clinic, it's still no guarantee that that physician's going to deliver your baby. As I tell my clients, it's like McDonald's, honey, whoever's working that day. That's like that is in essence of what it is. So I started to feel this need to want to help my clients that did have that limited support as much as possible. And the big picture of things, I want to offer childbirth education resources at the health center where I work. And it just made sense. Like if it was a math equation, I was just like, something's missing in here. We have doctors. Like I've been working with doctors for 8+ years. They're not telling me nothing new. Well, they're not, like in terms of how to make the patient feel more confident going into the labor room and just feel more confident in their bodies during their pregnancy. And giving them the necessary tools and skills to do that. And I wasn't finding that within my own practice. And unfortunately, we do not have certified nurse midwives within my practice. And I don't know, just something about the doula role just called out to me, just in terms of what it offers. But I've been on my own journey within that role in itself. I know I'm jumping ahead a little bit, but like it's always interesting that there's an emphasis to say that doulas offer non-medical support. But what gets tied into it, which I think is false, is the assumption that doulas don't have medical knowledge.
Right.
Because that just doesn't make sense to me. How am I going to support the pregnant person in their pregnancy or in their delivery or postpartum if I don't have some medical background? And not to say that the doula needs to be a nurse or anything like that, but just have some comfort level with the language and just the information. And so I guess I'm also on a journey to push for that change, but even within the doula world.
Yeah, I mean, I used to I was a birth doula for a long time, and I did a lot of education because, like both of us, all of us, I love to do that. And it was so interesting over time that some doulas that I've met over the years, they go to their 2 or 3 day doula training, and then boom, they're a doula, and that's like all they needed to know. And sometimes there's a lot of misinformation or a lack of information.
Yep.
And at the base level of what a doula is, it's providing support, and you're not supposed to be, telling them what to do medically,
Right.
but you should have more understanding so you can not tell them what to do or say, yeah, I think you shouldn't do that or should do that, but to have an intelligent conversation to help them understand the options or what might happen next.
Exactly.
And, the way that, excuse me, Lorenza and some other colleagues across the land who teach doulas are like, we're not just going to do a 2-day training. We're going to do a lot longer than that. And we're going to really do mentorship and, really work hard to make sure that the doulas are trained in a much more holistic and thorough way. And that's lovely. So it's great.
Yeah.
Got it. So Accompany Doula Care. So
Yes.
can you tell a little bit more about what that is?
So Accompany Doula Care is, and what I believe, the first of its kind in this state, is that they are a standalone funded standalone doula agency whose focus is on decreasing health disparities. And one of the ways to do that is by having more access to doula care services to clients of low socioeconomic backgrounds, by going through their insurances. Because I mean, if everything's covered by insurance, if it's part of your insurance coverage, there's no issue, in essence. So we are currently partnered with 2 health insurances, and I think not the world, but the Massachusetts other health insurances within the state are watching, to see how this goes. Are we able to do this work with this model? And I'm happy to say that it's working. It is working. And so part of Accompany's work is around advocacy for the doula bill that we currently that's currently up in our legislation to have Medicaid Mass Health cover doula services for all.
That'd be amazing.
And that would be amazing. Yes, we could see, a lot of the hope is that we could address a lot of those health disparities that we're seeing.
Mm-hmm. Yeah. All right. So speaking of doulaing, it's a nice verb. So
Yes.
I would assume that you don't act as a doula for your own patients of your own practice, or do you?
Correct.
Okay.
I do not. But they get my doula tools.
Yeah.
So, which I love, and that's why I do feel so happy that I trained to become a doula, because it has completely transformed how I do prenatal care. So yes, unfortunately, I'm to my patients, because they tell me all the time, "Be my doula." I'm like, I put you enough in the office. But no, but what I do for them are I am fortunate at my practice. We have 30-minute prenatal visits.
Oh, wow.
Well, most of our visits are 30 minutes.
Nice.
That is something that's very unique to our clinic, and I love. But prior to me becoming a doula, was I using all those 30 minutes? So now, after my doula training, I am able to have more in-depth conversations, or even demonstrate different stretches, spinning baby techniques, for pain, or have a more in-depth conversation about pain management options and non-medical pain management interventions. Yeah, becoming a doula has completely transformed how I do prenatal care. And yeah, sorry to like light up and like can't even get my words, because it really has been transformative. But yes, so one of the perks of when I reached out to a company to work with them, I had to very much make it known. I was like, I need to work like in the South Shore, because I work in Roxbury. So I need clients not going to Dimick.
Yeah.
And so it's worked out. Like, I haven't had any overlap. I mean, also Boston, Massachusetts is a medical beacon. Like, how many hospitals do we have? So it's been fine. There hasn't been any issue. Look, knock on wood, there has been no overlap. And I think that's just because I have the right people on my team who are helping to make sure that doesn't happen.
Yeah, no, that's good. So how do you balance the fact that you've got knowledge and experience in OB-GYN care when you're working as a birth doula, you're at a birth, and you're seeing what they're doing. Sometimes it's appropriate, sometimes it's not appropriate. I'm sure, like any doula, you see things that you really wish they weren't saying or doing. Do you try to like come in and just like, you're just a doula, like you're not telling anybody that you're also a nurse practitioner who works in OB-GYN, or are you making sure that they know that that's your background? Like, how do you balance that?
So I personally don't say what my background is, but I don't have actually the option, because my clients more or less blurt it out. They're like, she's a nurse, she's a women's health nurse. And I'm like, don't make them angry. But no.
right, because that like can create an issue with the care providing team,
or a pissing contest, as I like to call it.
Exactly. It shouldn't cause an issue, but they can perceive it.
I will say that I fortunately haven't had that experience yet, but I do sort of tense up in those moments when the client does like announce it. But at the same time, I lean into it, because I'm like, yeah, I know my, I was about to curse. I know my stuff. I know my stuff. So I am here just as a doula, but I know my stuff.
Yeah.
Mr. or Missy. So yeah, do your job. And that's in essence what I want you to do. Just do your job.
Yeah.
And I want us to work together. Yeah, I would say I take that back. I may have had one experience where there was some territory going on, but I don't even think it was so much about me being a nurse practitioner. I think it was just the old dynamic of nurse and doula, which that's going to be that should be a whole different topic for y'all.
Oh gosh, that should be a whole different topic.
That's a whole different podcast session conversation. Yeah, but I lean into it. I don't shy away from it. I've also had the practice because I am a SANE nurse, which in that role I am just, and I don't say that to devalue it.
A SANE nurse, meaning the sexual assault.
So nurse examiner, yes, sorry. So in that role, I am practicing from I'm a specially trained registered nurse in that respect. They don't know in the emergency rooms when I go in to do those kits that I'm a women's health nurse practitioner. And yes, sometimes the ED residents are doing some questionable women's health prophylactic treatments for STD stuff. And I think it would be wrong for me not to say anything, but I come at it from a respectful way. I come at it from a sign of respect. And at the same time, even in my role as a sexual assault nurse examiner, I'm still specially trained. So it's still in my purview. So let's have a conversation. I'm not trying to tell you what to do. I'm just telling you, this is what I've been trained as the ideal way to handle this scenario. Right. And it's the same thing with the work that I do as a doula. Yes, I know I'm a women's health nurse practitioner. I get that, but I also recognize that my area of expertise is more in the outpatient setting. So even in that role as a doula, I still have to check that and recognize that the nurse is still the expert in labor from the hospital standpoint, but from providing support and comfort to the client, we're going to do that together. You have your tools and skill sets to help the client, and I have my tools and skill sets to help the client. And let's try to combine those and do the best job for the client, so that they have the best experience.
So how many people are you going to be training in the next year to duplicate yourself?
Yes. Can you clone yourself?
So I don't know yet, because I recently applied to based instructor program.
Oh, good for you.
Because I do want to create a program to help and to do peer education for doulas in Massachusetts, as well as other nurse practitioners and anyone else who wants to learn more from the outside of the medical lens, because that's how we were trained. Nurse practitioners, women's health nurse practitioners were trained from a medical lens. Everything from A to Z that we learned, and at least in my NP program, was from a medical lens. I would have loved a certified nurse midwife to come and talk even once, just to offer that different perspective. But I think there is something special there with the women's health NP role that we can add to that medical model of care. So, when you get care from a certified nurse midwife, you're definitely getting more a physiological experience, less medicalized. But I think that's where the women's health NP can step in for that collaborative care that they do with the hospital and with the physician, to give that, I guess, that more nurturing care that I feel clients get when they have a certified nurse midwife.
That's awesome.
Yeah.
So Jeanette and I have spoken at length on this podcast about the current American maternal health crisis and how it is failing birthing folks and families, from our over medicalized over medicalization of a healthy human experience to the impacts of systemic racism on Black, Indigenous, and other people of color, birthing folks. We have many areas of improvement to work on. And in the meantime, too many of our community members are suffering. So as a fellow doula nurse, which is what I like to call myself sometimes,
Yes.
and in your case, what I mean by that is as a nursing professional who now has this view of the birth world through a doula lens, do you have any final words of wisdom or any take-home messages for our pregnant listeners, especially any first-timers who are preparing for this once-in-a-lifetime experience in a broken system?
Yes. Okay. So number one, your pregnancy experience, what I would want to say to all mothers, your pregnancy experience starts before you get pregnant. Like that, period. It starts before you get pregnant. You should not be looking for your OB provider once you're pregnant. No, you should already know where you're going to go, and do your research. Talking to your aunt, your mother, your friends, that's not research, that's taking opinions. That's taking a poll, that's a survey. No, you need to do your research. Another thing I would want to say is in pregnancy, and I know the American culture doesn't promote this, you should be in like one of the best physical shape like of your life. It should be before you get pregnant. It's not talked about enough. And I guess what I would also say is that it is in pregnancy for a lot of women, especially women of color or women of low socioeconomic status, where those underlying chronic illnesses can come out. So again, please, healthy eating choices, exercise, not developing any new drug habits or stopping one. All of those things
don't pick up
important.
Smoking.
Yeah, like all of those things are important. They really are. And then with the other thing, I guess in terms of like, using a doula, doulas are not superheroes. They're not superpower. They do not have superpowers. I like to think I do, but I don't. So like doulas are not going to cannot stop you from dying in labor. Like we do not have that power. What we can do is to support you by educating you, pointing you in the right direction of resources and literature and providers who will help to support the birth experience that you want to have. But also at the same time, you also need to ask yourself and understand what type of birth experience that you want. And no one should be telling you that.
But
okay, I'm done. I'm off my soapbox.
No, I love all that.
No,
I want to add a caveat. If you think when you're pregnant, this is the kind of birth I want to have, and then you talk to 5 doulas, and they pretty much are all saying the place you want to go and the care providers you're with are very unlikely to provide you with that experience you're telling us that you want. Listen to them. It's so frustrating to see people who are like, I know, okay, but I mean, they're nice, and my friend told me they use them, so I guess, it's too late now. I'm 20 weeks pregnant. I'm not going to switch care providers now. And you're like, you're telling me you want A, and your care providers in your hospital rarely does A. So run. It's okay.
So I guess for me, that has been one of the hardest things to deal with as a doula and a women's health nurse practitioner, because as you guys have been so kindly saying to me, like, I know stuff. So like I am a breath of knowledge and information on both sides, in my opinion, of the spectrum. So but what I've found, unfortunately, with some of my clients, I can bring them to the water, but I can't make them drink. And that part for me has been the hardest part. That again, I think comes with that that longer training for doulas, of understanding that like it's not your job. Like you are not that patient's, you're not that client's parent. You're not, that you are their support person, and that's all you can do. And then at some point, that is like there's nothing more to be done. Like you've provided them with everything, they have to want to use it, and you can't force them, because I know otherwise that makes you no better than somebody else than the medical practice that we will talk about. But so that will be, I will say that has been the one challenging thing. It's just like providing all the resources, but still potentially not having, as a doula, and not having a client like utilize it. And like, you know, like, you wanted a doula, like, I can do this, like I'm here to offer you all these things. And yeah, but that's the reality. It's still ongoing, my coping.
No, I actually,
ongoing.
like, that's actually one of the things that was impressed me the most. Cause for example, there are some home birth midwives that have their own patients that they care for and deliver at home. But if a client, you know, doesn't want home birth services, they will also provide doula services. So there are some home birth midwives that will be both a doula in a hospital and a home birth provider at home.
Yep.
There are as many, if not more, that won't ever do that, because now that they have been the authority in the room, or, you know, the person that's part of the shared decision making, stepping into the subordinate role where you're bottom on the hierarchy with all this knowledge and you know, it's hard. It's like, it hurts your soul. So I give you a lot of credit.
No, so I mean, if I'm being honest, and I've even talked to Lorenzo about this, it's like, yeah, I don't know if there's longevity with me for doing these two roles at the same time because of that. Yeah, like I'm afraid of like burning out, or just like feeling like I'm like banging at a wall, and no one banging at the door and no one's listening. So and that is actually what led me to and I started to look more into the childbirth education and the peer education, because with both of my roles as a women's health nurse practitioner and as a doula, working with the two separate groups of patients or clients, I use the terms interchangeably now, I always get it mixed up. But education, that is the core, like that is the root. I don't say it's a problem, but it could solve so many things, and make the information I feel that I'm providing as a doula, or even as a women's health nurse practitioner, more digestible to the patient. And yeah, there are not enough, in my opinion, like accessible childbirth education programs in Massachusetts and the city of Boston, where I practice primarily, that are free or not in the medical based perspective. And it's just like, I want to use like the doula model of care, which is just, I'm just here to present you with the facts. I'm going to give you the information on both sides, and you make the decision once I give you this information, what is best. Where I feel primarily a lot of childbirth education program classes are giving you the information from what biasly. And I get it. Like, you know, if the hospital paid for it, they're going to they're going to incorporate the things that they want you to know about delivering at their hospital. I get that.
That is why Melissa and I no longer work at hospitals.
However, exactly.
Both Melissa and I have experience out of some of the hospitals that we worked with. There were hospitals where we were supported in providing evidence-based information and alternatives, including talking about home birth if a client asked about that option, even though they were currently seeing a hospital-based provider. Sometimes you can find that thorough, in-depth childbirth education even through a hospital system class, but not most of the time.
Yeah, not most of the time.
Right.
And I know you said, Ketura'h, that you don't catch babies, but I say never, because I
that
think
water
that
show. I like the top of the bed. I mean, I spend enough time at the bottom of the bed. And also, so it's funny, because my patients and my clients and colleagues and friends, they say it all the time, especially when I just talk about the work that I'm doing now. They're like, your face just lights up. I can really see this is your passion. I'm like, it is. But what I do truly love about being a women's health nurse practitioner is that I get to do both. I get to do OB care and I get to do GYN care. Yeah. Like, I love putting in IUDs. I love cutting out Nexpanons. You didn't hear me say put them in, but I like taking out Nexpanons. I like that. My background is chemistry and I did cancer research when I was an undergrad. So like I don't say I enjoy, but I like helping my clients who have abnormal pap smears. I perform colposcopies myself. And yeah, there's not that many nurse practitioners, do as many procedures as I do. And so like, I love that. And the thing about nurse practitioners is that just like you have physicians in their specialized care, nurse practitioners they're specializing in a focus. So you have family, which they do the whole lifespan. That can be challenging, and kudos and hats off to people who do that. But I wanted to specifically focus on women's healthcare. I wanted to be an expert in that. And I think the work and the skill that you need to provide, like to be a certified nurse midwife or an OB, that is specialized care, and you should just be, concentrated on that. I understand that because it's to me it's scary, but like wonderful, like I said, God's work, like it's amazing. It's an amazing role to be in. It's just not mine.
Well, if your goal was to learn so much about this passion of yours, women's health, I think you have succeeded in that goal.
Oh, thank you. I think I'm still learning. I'm still looking at more things to do. And like I said, I want to help peer educate my fellow NPs, because I want to make sure that we're doing our patients justice. And I know we have the medical side of things down packed, but it's those little things like telling the mama to go get a yoga ball, and introducing her to spinning babies, or just stretching, having those in-depth preconception visits to talk about the importance of exercise and being physically mobile and healthy eating, and how impactful that can be, not only before pregnancy, after pregnancy.
Well, I know that if anybody has listened this long into our show, which I think they would have, because you're so dynamic and interesting to listen to, if somebody wants to come and see you because they want you to do their colposcopy, or they want you to do their IUD placement, can they just do that? Or is there, because you work at a community health center, is there something they can just call you? They can call your office.
Yes, they can call the office. They can book an appointment. The only barrier would be, depending on their insurance, they may need to get a referral from their primary care provider. But that's no different from any practice if I was in private or a community health center. So come on down to Roxbury Academic Center. I'm there.
I hope people will.
Yeah. Well, thank you so much for coming on our show and sharing so much wisdom and energy and passion with our listeners.
Oh, thank you for having me. I loved
Breath
it.
of fresh air.
Yeah, it has been an honor to have you on our show. And if I didn't already have so many people in my life that can do a pap smear for me, I would come down to Roxbury and get one from you. So thank you again for being on our show. I've learned a lot. I hope we get to collaborate more in the future somehow, because I find you amazing. So we hope everybody that's been listening has enjoyed the show. We hope you will tune in again. We hope you will visit Ketura'h in Roxbury, and remember that Babies in Common is a community for you. After all, we all have babies in common.